initial conservative treatments. Now we're thinking about surgery. But I typically don't tell people that they need a joint replacement. This is truly an elective procedure. It's typically not seen as an emergency. So the better question is really, why should I get a joint replacement, or should I do it? And some of the reasons to do it, of course, are if nothing is helping you. You're having pain in your hip, your knee, the injections, the medications, physical therapy, whatever you've tried, nothing is helping, and this is truly ruining your quality of life. And that's really the main thing that I'm looking for when I'm talking to a patient, to try to decide if they're a good candidate for this type of surgery. If it's ruining your quality of life and the simple stuff is not helping, then joint replacement is a very good option and a way that we can get you better. One of the other reasons to do it at the bottom is we talk about deformities. You may not have so much pain, but if your knees are really angled, that it's making it harder for you to walk, that you're either knock-kneed or really bow-legged, or your legs are shorter, or one leg is shorter than the other, that can be fixed also with joint replacement. And this is just an example of what I'm talking about with the deformity. You may see someone who is walking with a really angled leg and they're limping severely. They may actually not be in that much pain. We see it from time to time, but we can get that person walking better with a joint replacement and straightening the leg out. As far as the outcomes of joint replacement, I get, again, asked this a lot. How does it work? How do people do with it? Knee and hip replacement is probably among the most successful surgeries we do in all of medicine. I tell my patients, especially for hips, that it's probably the best surgery we do in all of orthopedics. Both of them have satisfaction rates at or above 90%. And the basics of the surgery is we remove the damaged portions of the bone and cartilage and resurface the ends of the bones with metal and plastic. And that's to get your joint moving again, and it prevents the inflammation that the damaged cartilage is causing from reoccurring. And so this is a basic image just showing how kind of hip replacement goes. So we basically remove the head or the ball of the femur, and we clean out the inside of the socket. So that's a picture of us cutting off the femur, and that is called a reamer. It cleans out the damaged cartilage and bone within the socket. You then get a new metal socket inserted into the old one with a plastic or some type of liner that sits in the metal socket. It's usually some type of modular piece so that that piece can be changed out if needed. Inside the femur goes what's called a metal stem that can either be glued into place, or more commonly is what we call press fit into place, where your bone will actually heal to it and adhere to this component so it becomes a part of you. So there's no artificial fixation. It's actually a biologic holding of that component. And then the ball goes on top of that stem, and that sits in your new socket. And so you can see the change from an arthritic hip to how a hip replacement should look. On the knee side, it's a similar idea. This is the lower portion of the knee, or the tibia. We cut off the top of that bone and cartilage and put it in a metal, what we call tibial tray, which is a flat surface and has a plastic liner sitting on top. On the femoral side, or the top of the knee, we again remove the bottom portions in more of a curved pattern, as that's the shape of what the femur is, and put on this curved metal component on the bottom as more of a cap, and that sits then on top of the plastic portion, and that's what gives you your new hinge at the knee joint. Sometimes we'll also replace the backside of the kneecap or patella with a plastic dome to also help smooth out the articulation between the kneecap and the metal femur, which is where it rests, and you can see that on this picture. This also shows the difference between a full knee replacement and a partial knee replacement. There are different types of partial knee replacements, but the basic idea is that in a full knee, we replace all portions of it, both the outside and the inside compartments, as well as behind the kneecap. In the partial knee replacement, you can see the white is still the normal cartilage within the knee on the femur, and on the blue is also normal cartilage on the tibial side, while the gray is representing the metal replacement parts of a partial knee replacement on that individual side. Reasons to do a full knee replacement versus a partial. If the arthritis is all throughout the knee, through all the compartments, then obviously the recommendation is do the full knee. But if you have only one area that's worn down, which we do see from time to time, and the rest of the cartilage is still healthy, then a partial knee replacement is a good option because it maintains more of your normal tissue. It feels more like a natural knee. There's less surgery, so it's an easier recovery, usually less pain. The risks or downsides of the partials are that they typically do not last as long as a full knee replacement. Typically, I tell patients that a partial knee should be expected to last about 10 to 15 years, while a full knee replacement is about 20 to 30 years. So we also have the conversation about potential of multiple surgeries, what you're looking for as far as your functional level. If you're running, playing tennis, more into sports, and you're a candidate for a partial knee replacement, you'll be able to keep up with that activity better with the partial than with a full. But if you're just basically walking, not doing high-level activity, a full knee replacement will work perfectly fine for you, and then it would save you the risk of having to have this redone potentially 10 years down the road. Just touching base a little bit about advances in joint replacement, where we've gone. Things are very different than they used to be even 10 years ago. Nowadays, for hip replacement, the way I do it is what's called the anterior approach. Classically, people had it done through what was called the posterior approach. The main difference is really where the incision is. The anterior approach is on the front of the thigh, while the posterior approach was on the back side. The other differences are the recovery, because we do less muscle cutting or no muscle cutting with the anterior approach versus the posterior, and we also keep all the main stabilizers of the hip intact when we go through the front or the anterior approach. The recovery is easier, there's usually less pain, and there's also less risk of dislocation. What I mean by dislocation is the ball of the hip joint can actually pop out of place because the ball and the socket are not connected. Through the posterior approach, generally it's considered that about 2 to 3% of people with that approach will dislocate sometime in their lifetime. With the anterior approach, it's less than 1%.
Are most doctors going with the anterior, or is it?
So she asked, are most doctors going with the anterior approach? And the answer is no. The posterior approach is still much more common. Anterior is becoming more and more common, but it's usually specialized trained, fellowship trained surgeons. General orthopedists or orthopedists have been in the community longer are, for the most part, still doing the posterior approach. And again, it does work well. I don't want to say it's not a good way to get a hip replaced, but we do feel that there are advantages to the anterior approach. Because it's more minimally invasive, it's a little more technically challenging, and that's why people who have been doing the posterior approach for a long time don't feel the desire to switch, because it can take a little while to learn it. For the knee replacements, one of the main advances that we've done over the last 10 years is what we call quad sparing knee replacements. Traditionally, that image all the way again on your left with the red line is how we used to enter into the knee joint. We'd cut right into the quadriceps tendon. While it would work well, it would heal, and everybody would recover, there would be weakness within the first 6 months after a knee replacement. So now what we've gone to is this quad sparing, where we don't cut the quadriceps tendon, we cut more onto the side of it. Again, it's more minimally invasive. It makes it a little bit tighter and harder to get into the knee joint, but for people who are trained on it, it works well, and people maintain more strength immediately after knee replacement, are better able to walk and function within the first 6 months. One of the other big things that has come down really in the last 5 years is robotics. This is a tool to just help assess our accuracy, make sure we're doing things correctly. You know, we've been doing knee and hip replacements for a very long time, and we've done a very good job with our traditional methods, but this is an advancement that's helping make sure we're as accurate as possible. It is not mandatory to have it. There are some downsides with it as well. We do have to put typically some type of pin or tracker into the bone to help make sure the robot knows exactly where the joint is, which could mean additional incisions. But the benefit is that it's making sure your joint replacement is put in the best position possible.
Excuse me.
Yes?
What brand of the robotics do you use?
So every company, almost every company I should say, has, she asked what brand of the robotics do I use. Every company has their own robot at this stage. Currently at St. Peter's, where we do our surgery, they actually do not have a robot. It's something we're talking about. The joint replacement company that we use at St. Peter's is mostly Smith & Nephew. They have, their robot is named the Corey, and that's what we're discussing, but it's not there yet. The most popular robotics out there is probably a different company called Stryker, but they all work fairly similarly. There's slight differences between them, but that would really be a topic for a different talk because there's a lot of specifics you can get into with the different types of robots and what they offer. As far as when I see patients, people who are older, have multiple medical conditions, I get asked this a lot as well. Am I healthy enough? Is this something I can really get through and recover? And I always say it's not really something that we decide right away. It's something we should take into account talking to your primary doctor, talking to your family, seeing what makes the most sense, evaluating your overall health. Most patients who are under the age of 80, I will tell you, are typically safe for this and do very well. Most patients, even between 80 and 90, and I do a lot of patients in the 80 to 85 range, or even a little older, are safe getting this done and do well with it. It's more concern of, do you have any major medical conditions that would prevent you from doing it? One of the big ones is obesity. We find that patients who are morbidly obese with a BMI, body mass index, over 40, puts you at significantly increased risk for complications such as infections, the implants coming loose, or other forms of failure. And so because of that, we really try to avoid doing joint replacements on patients with that body mass index over 40. Under 40 has been shown to be safe. There are other reasons to do it or not to do it. People who are on dialysis for kidney failure typically do not heal as well, also are at higher risk for complications. But generally, if it's heart disease, high blood pressure, well-controlled diabetes, you're perfectly safe getting this surgery done. But again, as I said, we always like to coordinate with your primary care doctors, your cardiologists, any other doctors that are involved in your overall care to make sure everybody is in agreement that you are safe to proceed with this. One of the final points I want to get into is, what if I already had a joint replacement? What is there to look out for? Am I good for the rest of my life, or should this be checked regularly? And one of the big things people ask, and we talked about a little bit, is about how long will this last? If you had a joint replacement done generally over 15 to 20 years ago, people were told that they should last about 10 to 15 years. Nowadays, with modern technology, newer implants, the implant should last at least 20 years, if not longer. And there are some people in our field who believe some implants may be as good as even 50 years. The science and the data hasn't actually shown that, but we know that these implants are lasting significantly longer than they used to. The next question is, how do I know if I need my joint replacement to be redone or have a revision surgery? And there are a number of different reasons. Pain is really the biggest one, the most common one we see. You've had a knee replacement 10 years ago, it was functioning very well, you had no issues, but all of a sudden you start to have consistent pain. It's worth getting it checked to see, is there something going on? Has something come loose? Has something worn out? Some of the other reasons are if all of a sudden your joint starts giving out. It's unstable and it never was before. You need a brace to help hold your knee in position. We can check it and see what happened. Did one of the ligaments around the knee replacement tear or become incompetent? There's ways that we can redo the knee replacement to make up for that and get you a stable knee again. Or did one of the implants become loose where it's moving where it shouldn't be? Going back in and putting in a new one that's well fixed will give you a better functioning knee or hip replacement. Other things, falls can cause fractures around joint replacements. Hopefully that doesn't happen ever, but if it does, there's ways of redoing the joint replacement to make up for that and get you back to walking. And then infection is, of course, can always happen. It's a risk. We do things as safely as possible, but if there is an infection in a joint replacement, generally antibiotics will not clear that infection, and a surgery is needed to do that. These are a couple of pictures of hip replacements that have failed. You do not see stuff like this that often, but it's just good to know that things like this can happen. Again, the top picture on your left is the hip that is popped out of place. That's a dislocation. The top picture on your right shows that the socket has shifted position and is no longer where the surgeon initially put it. Same thing with On the bottom left, the ball is no longer centered within the socket, which is a sign that that liner that's inside the socket, which is usually plastic, has started to wear out. And you can see that on the middle picture in the bottom, where you can see that cracking of that white on the left side, which is wearing out that plastic portion. And then all the way in the bottom right, it's a little hard to see, but that's actually a picture of that metal component breaking in the middle. That's pretty uncommon, but it can happen with enough stress through it. On the knee replacement side, similar ideas. The middle picture there shows that it's no longer even between the top and the bottom, the femur and the tibia, and that's a sign that the plastic has worn out, which that picture on the top right is showing that the plastic is no longer smooth, it's worn down. On the top left, you can see that the tibial portion has angled, it's shifted, there's been a fracture around that, and it's become loose. The bottom left, again, something happened to the knee replacement that it actually dislocated. And so on the bottom right also, the tibial component has shifted back. And so these are a couple of examples of failures. Usually they are not this obvious. Usually it's more subtle findings when we talk about redoing a joint replacement. So if you have a joint replacement, you're having pain, you feel like it's shifting, something doesn't feel right, it's changed from what your baseline was, it's worth having it evaluated. And typically we say that about 12% of patients who have had a joint replacement will need it redone at some point in their life. We do believe we're getting better at the initial surgery and these things are lasting longer, and that this 12% should go down in the future, but that's what the research has shown. I typically recommend that you have your joint replacement checked every 2 to 3 years to make sure that you're not having any wearing down of the plastic, that nothing is shifting position, just as a regular maintenance, just like you get your oil change in your car, get your tires aligned, it's the same idea. Again, just because you have a painful joint replacement, again, like we said before, if it started all of a sudden, doesn't mean you necessarily need surgery. Usually it can be treated with simple stuff, medications, physical therapy, braces. There's always options besides just surgery to treat most of the common reasons that we see pain after joint replacement. Again, and this is just a summary. Again, osteoarthritis is very common. We see it in the aging population regularly. There are a lot of conservative treatment options before we need to get to surgery. If you do need surgery, hip and knee replacement is probably among the most successful surgeries we have to offer in the entire medical field. Things have gotten a lot different over the last 5 to 10 years. Most patients, I didn't even touch on this, go home either the same day or the next day after surgery. 15 to 20 years ago, people were going in, spending a week in the hospital or 3 days in the hospital, and then going to rehab for 2 weeks. But things have gotten significantly better, that you are safe going home, you're more comfortable going home. We can set you up for different physical therapy options once you're home. So this is much more streamlined and I think a much more comfortable way of doing it now than how it used to be. Again, you'll forgive me for giving one more picture of my son.
I don't blame you.
Looks like his mother.
He does look like his mother. And again, so I'm part of Advanced Orthopedics. We have 2 offices, one in Monroe on Applegarth Road and Cranberry Half Acre Road in the Central State Building right behind the Walgreens. And we also have an office in Freehold. And this is our contact information. I'll open up for any questions that are out there now. We'll start on this side and work our way back. Yes?
You mentioned going for checkups every few years after the surgery.
Mm-hmm.
What does that involve?
So he asked about the going for checkups after surgery and what does it involve. Typically, if you're feeling well, I recommend an x-ray just to check the alignment and the position of the replacement parts. As long as everything looks good, I do a quick examination just to make sure I don't feel like anything's unstable, that everything's moving well, and that's it. As long as you're good, I say see you again in 2 or 3 years.
Mine's about 15 years old.
Mm.
And
When was the last time you had it checked?
never.
Nobody ever told me. I guess it's worth it.
That's the question.
Right. So again, typically we recommend it just to, again, make sure that there's no issues, because if something is starting to wear out, you want to catch it sooner than later. There's ways of fixing things simply by changing out some of the easily changeable parts and giving you a simple fix, as opposed to if it becomes where the metal parts actually start to shift, because then that becomes a much larger surgery. And that's why that we recommend the regular checking of it. It's not so much because we think something's going to happen, it's we want to catch it before something really bad does happen.
Very interesting.
Yep.
What's the timeline from surgery to being actually mobile to getting back on the pickleball court?
So he's asking about recovery from surgery, which is a good question. So it's a little different between hip and knee replacement. I'll start with the hip. I think hip replacements are easier to recover from. I tell my patients I expect them to be walking comfortably again in about 6 weeks. For the first 6 weeks after hip replacement, my restrictions are there's no running, jumping, heavy lifting, impact activities of any kind. Once 6 weeks are up, you're allowed to go back to full activity once you feel comfortable. Most people will get back to that full activity by 3 months. Up to a year after your joint replacement, though, you can still note, and this goes for knee replacement too, you can still note some swelling in the extremity, especially with increased activity at the end of the day. You may notice swelling in the leg. Scar tissue changes can happen over the course of the first year, so you may even notice some popping or clicking within the joint interchangeably when like a tight band of scar tissue forms. But functionally speaking, I would expect you to be back playing pickleball by 3 months. As for the knee, it takes a little bit longer. Full knee replacements are a bit more painful, a little bit harder recovery in the initial phase. I usually tell people you're in formal physical therapy for at least 6 weeks. I expect you to be walking more comfortably by 6 weeks, but it will take usually a full 3 months before you are satisfied that you had the knee replacement done. Again, full recovery for strength and range of motion can take longer, 6 months to a year after knee replacement. So it's a little slower getting back after knee replacement for some people. All right.
I have to go.
Yep.
The protocol for the gel injection.
Mm-hmm.
Some physicians, I understand, do once a year, some a series of 3. How frequently can they be done?
So the gel injections, she's asking about how frequently can they be done, what's the difference between the protocols. So it's an interesting question because the gel injections can be done every 6 months, but that's because that's what the insurance tells us. They will only pay for it once every 6 months. Technically, if you want to get it sooner, there's no medical reason that they can't be done sooner, but you'd have to pay out of pocket for it, and they can be very expensive. As far as the protocol, the different types of gel injections, there's series of injections where you come in and get 1 injection every week for 3 to 5 weeks, or the single shot that you do it one time and that's the end of it.
Is it a different medication?
It's the same medication between the two, it's just in different amounts. When this medication was initially developed, the idea was we want to introduce it over time to have it bind and fill in those gaps more. And so it started off as these 3 to 5 week injections. As time has gone on and we've better developed it, we found by giving a certain amount at once, it works just as effectively. That being said, some people respond differently to the series versus the one shot. We don't really know why. It's just based on every person, how they personally feel about it. Some people like the series better. Some people like the single shot better. I typically do more the single shot because I think it works just as well as the multi-shot. But if a patient comes to me and says they've had both before and the series works better for them, I'll do the series.
One other question.
Yep.
Can that be done in the hip?
So she's asking, can the gel shots be done in the hip? And that's a good question. So the FDA, which decides where all medications go, has only approved it for the knee. Now, there are some doctors who will do it off-label. I personally do not, but I know we have doctors in our office who do. I'd have to ask, or you'd have to ask them how they get it approved outside of FDA recommendations to do in the hip. But I do know doctors who have done it in the hip and the shoulder as well. Yes?
Probably this is what you avoided talking about before, platelet therapy? Is it a real thing, or is it just, I mean, I know it's real.
Right. So the question was about platelet therapy. So there's platelet-rich plasma, which is, we draw blood from the patient, We spin it down in a centrifuge, and the idea is we take the healing factors from it, and then we re-inject it into somewhere to help promote healing. This originally was developed for like ligament injuries, tendon injuries, where there's a lot of healing potential. And it seems to work well for that. With cartilage that's been worn down though, there's really not that same healing potential. So by putting that PRP in there, the signs of why it should help doesn't really make sense. We're not regrowing the cartilage. Now, does it have some anti-inflammatory benefit like what cortisone would do? Probably. It probably can help calm down the inflammation within the joint, so there's some potential benefit to it, but it's also, again, not covered by insurance, which means it's an out-of-pocket cost, which is why another reason I typically don't push for it, because the science doesn't really make sense, and to ask someone to pay an exorbitant amount out of pocket for something that scientifically doesn't have a good basis, I don't feel comfortable doing. Other people will ask about stem cells, which is a totally different thing, and it's the same thing. The science doesn't support its use. There's no reason why stem cells should help regrow cartilage, and it's even more expensive than the PRP. Yes?
If the steroid shots are working, is there a limit on how many before it becomes very detrimental?
So the question is, if the steroid shots are working, is there a limit on how many before it becomes a problem? As far as total number, not really. It's more the time span. Again, the science shows that within 3 months of each other, the amount of steroid can really start to weaken the tissues within the joints, wear down the cartilage further, or even weaken the bone. As long as you space them out by that 3 month, it's usually considered safe enough. The bigger thing is eventually your body builds a tolerance to it and it becomes less effective. For some people, it'll be 2 shots. For other people, it may be 12.
Mine seem to last 8 or 9 months.
Yeah, and so then you're spreading them out by plenty, and then I would say you can keep doing it until it starts working less. Yes, in the back.
You talked about impact activity. Let's use the examples of either walking or pickleball. Is there anything preventive? Is there anything that one might do to lessen any kind of injury?
So she's asking, based on type of activity, is there anything we can do to lessen the injury from activities? So with arthritis pain, typically impact activities will make the pain worse. So running, jumping, simple walking is usually not as bad. If you're talking about exercising, biking, exactly, is better than treadmill because your feet are planted and it's more motion-based. So typically that is more well tolerated. Elliptical, same idea, because your feet are planted on a surface and it's more just motion, that's usually more well tolerated. As far as preventing injury, it's more the simple stuff that you've kind of always been taught. Warming up, stretching, if you need braces to help keep things from swelling, your normal type of pattern, and being careful with your motions. The biggest cause of injury isn't necessarily just the motion or exercise you're doing. It's, of course, an accident, something that didn't happen, a bad step, that you twist your knee, or knock on wood, a fall. But basic activity, I usually recommend you keep up your activity, honestly. And part of the reason is arthritis gets more painful when you're not being active. When you're sitting around not doing anything, that's why you get that startup pain. When you first get going, it feels stiff, it's painful. As you're more active, as you're doing things, arthritis usually feels better, and it helps maintain the health of not just your whole body, but your joints as well.
There's an exercise piece of equipment that they advertise on TV, and it's for a sedentary person sitting in a chair, and I don't know if it has a benefit for either the knee or the hip. It's not a motion bicycle. It's, again, something that you just kind of use your feet to.
Right. It's like a pedal stepper in front of you. Yeah. So she's asking about a device that they're promoting. So the basic idea for that is, again, to maintain some motion in the joint, just to keep things moving. So I didn't get into this, but the reason that your joints feel worse when you're not moving is because there is a normal amount of fluid that should be in your joints. It's like, again, a lubricant. When you're not moving, it kind of settles in and things stiffen up. It's not moving. We feel better when that fluid is circulating. So by doing constant motion like one of those pedal things offer, it helps keep that fluid moving. It usually helps you feel better. Will it treat anything long term? No, but in that initial instance, rather than sitting around not doing anything, it could help prevent you from developing that stiffness when you first get up or the pain. Any other questions? Yep.
How do you know somebody is a candidate for the anterior approach?
So
Who is everybody a candidate?
Right. So she asked, how do you know if someone's a candidate for the anterior approach for a hip replacement? I only do hip replacements through the anterior approach. I think everybody's a candidate when it's your initial hip replacement. When we get into revisions or redo surgeries, it's a little different. Somewhat depends on what approach you had initially, somewhat depends on what the problem is. Again, because it's a minimally invasive approach, it can be a little more difficult to do complex surgeries through it. But typically, I consider almost everybody for an initial hip replacement to be a candidate. Any other questions?
So is the recovery easier, for lack of a better word, than the posterior with a hip replacement there?
Right, so she's again asking, is the recovery different between the anterior and posterior approach? So I think so, and most people will agree. With the posterior approach, we cut some muscle, we cut some of the stabilizers of the hip. Typically, there's a little bit more pain because of that. You're also given what we call hip precautions, where there's certain things you're not allowed to do initially. They tell you to sleep with the pillow between your legs. You can't cross your legs. You can't bend over too far, all that stuff. With the anterior approach, because all that stuff is intact, I tell you, you have no hip precautions. You can basically do whatever you want as far as motion goes right away. Also, because we don't cut muscle, your body actually has a natural plane between two muscles that we use. There's less pain with the anterior approach. Most patients who I do this for, I don't even give them physical therapy. I tell them go home and walk. And that's all you need to do. So the recovery typically is easier in the initial going. Usually though, as long as everything's gone well in the first 6 months, by that point, most patients will say there's really no difference between the approach that you've had done. So like I said, long-term both do fine. It's more in the initial, not having to do the hip precautions, having a little bit less pain, a little easier walking.
How long have you been doing the anterior approach, just out of curiosity?
4 years.
Okay, thanks.
Is there an age that you would cut off, that you wouldn't do surgery anymore?
Not necessarily just an age, it's more the overall health condition. So obviously the older we get, the harder it is to recover from surgery. But if you are, I see plenty of people who are in their upper 80s who are healthier than some people I see in their 60s. So there's no reason, if they have a bad joint, not to get them back to their quality of life just because of their age. If someone comes in, they have major heart problems, they're on dialysis, or some other reason why I don't think they're safe to undergo the surgery, it doesn't really matter what the age is. But I've done joint replacements on, for sure, people at 89 and 90 before, when they really need it.
My neighbor had it done in 94.
You referenced something about the anterior approach that required some special experience and skills. What complications can there be?
So she's asking about getting the special training for the anterior approach and what complications there can be. So it's because it's a minimally invasive approach, it's a tighter window, for lack of a way of putting it. You need to be adjusted to it. An experience matters as far as learning it. It can be difficult to learn how to do it. It's also working a different direction from the posterior. So someone who's done hundreds of posterior hips, they have to adjust to learning how to do it the opposite direction, basically.
Is there complete visibility when you get
Complete disability?
visibility?
Oh, visibility, absolutely. Yeah, if you're trained well enough, I know how to expose everything. I can see everything. I have no difficulty. Some of the other benefits, though, of doing it anterior, which I didn't get into, are you're laying flat on the table on your back. When we do the posterior approach, you're up on your side. So it's a comfort thing. It's easier for anesthesia. Knock on wood, God forbid anything goes wrong. You're on your back. What's that?
And I was up.
Yeah. Well, we do it through a spinal usually, so you are kind of awake. The other thing is we can affect your leg length during the surgery. When you're laying on your back, it's very easy for me to check your leg length, make sure it's accurate. When you're laying on your side, it's a little bit hard to really make sure that's accurate. And then the other thing is it's very easy to check x-ray in the operating room when we do it through the front, when you're laying on your back. When you're on your side, it's much harder. So I typically check x-ray during every anterior hip replacement I do because it's easy, it takes a few seconds, and I make sure everything's in the right spot. Some of the complications, just to answer that part of the question, for anterior approach, if people aren't experienced, is yes, they don't get as good visibility, and it can be harder for them to put the hip replacement in the correct spot. And there's increased risk of fracturing the bone if they don't know how to expose it correctly. Was there another question coming?
Yes, there was, but it just left my mind.
Sorry. Yes.
You ever have people do both knees at the same time?
Yes. She asked if we ever have people do both knees at the same time. And so the answer is yes. I usually have a talk with patients who are interested about it. It's a more difficult recovery. I tell everybody that, you know, even though your knees are bad, you know what to expect out of them. When we replace them, you may not know. So it's typically easier to do one at a time because at least you have a leg that you can kind of rely on, even if it's not a great leg. It is also a lot more surgery to do both at once. So if you have any medical problems, diabetes, heart conditions, a lot of times your primary doctor may recommend doing only one at a time. Depends on your function. If you're using a wheelchair or a walker to get around mostly, you may not have the strength to recover both at the same time well enough. And it may make more sense so that you can focus your energy on recovering one knee at a time. So there's reasons to not do it. There's also reasons to do it. If you are very functional, you're getting around, it's just painful, or you're getting your knee replaced because both of them are really angled, there's a major deformity, where if we just do one, you're going to be lopsided by not having done the other at the same time. That's actually a reason to do both at once, so that you're more even. So it goes back and forth. I typically do one at a time, but for the right patient, the right reason, doing both at once does make sense. And the same goes for the hip also. It's a little bit less common to do both at the same time with the hip, but if someone's active enough, both hips are bad, there's reasons to do both at once. Yep.
If you were to do only one at a time, how soon can you do the other one?
So she's asking about the timeline. If you do one at a time, how soon can you do them both? And usually I recommend at least 6 weeks between the two for either hip or knee. It's just to give you enough recovery time that you feel like the one we operate on is now your good leg, basically. Some people take longer than 6 weeks, and if that's the case, we push it off. But I want you to feel, again, like you have a leg that you can trust during the recovery of the other leg.
Just break out a leg to stand on.
Exactly. Again, we do this to get you back to walking, get you back to your activity. If we do a joint replacement and you end up in a wheelchair, that's a failure. That's not a good outcome. So we want to do everything we can to make sure this is as successful as possible. So if by staging them, doing one at a time is going to give you a better outcome than doing them both at once, then that's what makes more sense.